Hello and welcome to our CMF podcast. I'm Dr. Rajiv Agarwal, Professor of Medicine at Indiana University School of Medicine in Indianapolis. The CMF is a free educational resource for clinicians, and this podcast aims to keep you up to date with the latest data presented at the American Society of Nephrology's Kidney Week 2023. I'm delighted today to be joined by my colleague, Professor Meg Jardine. Meg?
Hi, Rajiv. Yes, thank you. I'm Meg Jardine. I'm the director of the NHMRC Clinical Trials Centre at the University of Sydney and lead of the CTC's Kidney Health Research Team. So today we'll be discussing some of the key abstracts of many presented at this year's Kidney Week 2023. And I think we're both excited to talk about some of the things that really stood out for both of us.
And here are our disclosures. So ASN's Kidney Week this year was held in Philadelphia, and it was great to attend another meeting and catch up with colleagues to discuss the latest data. In addition, there were a number of interesting clinical trials which may have a real impact on clinical practice. These are typically discussed in the late-breaking clinical trials, either in the presentation or the poster sessions. And that's where we have typically taken our highlights from. I would like to begin this podcast by discussing some of the abstracts I thought were of note. And here are my picks. I will start off with aldosterone synthase inhibition with or without background sodium glucose cotransporter 2 inhibition in CKD, a phase 2 clinical trial. This was really a remarkable trial presented by Dr. Kathy Tuttle from Spokane, Washington, at basically getting a new ASI, but in patients with CKD. There are other ASIs like lorundrostat. Basically, those are drugs which are used in patients with resistant hypertension, but none of them have been used in patients with chronic kidney disease. In this case, it was the first time a Boehringer-Ingelheim compound 690517 was being used in patients with CKD. The novelty of the study was that initially they randomized patients first to get either empagliflozin or placebo for an 8-week run-in, and subsequently they randomized each of the two groups, EMPA or placebo, to the ASI compound in 3 doses, 3, 10, or 20 milligrams, and compared it to placebo. Their primary outcome was to look at the change in USCR from the first morning void urine from second randomization to week 14. And they also looked at the number of people who had USCR reduction of 30% or more from R2 baseline to week 14. What they found was pretty remarkable improvements in ASI, with ASI, regardless of whether the patients were on empagliflozin or not on empagliflozin, which suggests that these are drugs that are working on top of empagliflozin, which has become the standard of care in people who have proteinuria kidney disease. And the effect was quite remarkable, about 40% for the 10 and 20 milligram dose. So what they conclude is that this was well-tolerated, dose-dependent, and reduced USCR on top of background RASI, and EMPA or placebo didn't make any difference. They also found that there was slightly more anti-albuminuric efficacy in people who had empagliflozin on board. The problem with this study was that they had a fairly low incidence of hyperkalemia, but the change from baseline in serum potassium was substantial. It was about 0.3 milliequivalents, which is quite a bit more than what we see with other agents such as finerenone. So we don't know whether when you do a phase 3 trial that a similar number of people will stop the drug or not. Here, 4% of the people went off the study drug because of hyperkalemia. And that happened within 14 weeks. If you're doing a 14-month study or 3-year study, this number might increase. So that is still not sure if it'll pan out. Nonetheless, they have announced a 11,000 patient trial now to look at the safety and efficacy of this compound in patients with chronic kidney disease. And that's really an astoundingly large clinical trial. Megan,
that's a really
yeah.
Sorry, Raj, I was just going to comment. That's a very big number, and what that tells us is how potentially individually powerful the compound is. Yeah, with the SGLT2s around, we have such a reduction in end rates that that to show whether a new agent is going to work, we need those big numbers. This is historically, this is a really profound place for CKD to be. Really, really exciting. And I think the other really interesting thing here is that we are now moving into the big trials of compound agents. We've had the SGLT2s individually. We had finerenone demonstrated in the Fidelio and Figaro studies. Now with these agents, the ASIs, which are filling that niche along with the MRAs, we're now starting to look at compound agents for these two and a couple of others we're talking about. It's really moving kidney disease forward, isn't it?
It truly is. And you look at the size of the trials, the renal trial that was about 20 years ago was about 1,500 patients. And when we did the Credence trial, it says, oh, this is so much larger than renal trial. And that was about, 2,300 patients? And
4,400, yeah.
2,400, yeah. And then we did the Figaro trial was about 7,500 patients. Figaro Fidelio put together was 13,000 patients. And here it's a single trial going 11,000 patients, which truly is quite astounding. So I think we are really getting into the mega trial phase. And that is perhaps not so much because we want to, it's because it's harder and harder to show risk reduction when you're reducing the event rates by using effective therapies in the placebo group. When you use the standard of care, that improves the rates of outcomes, and that's why we're doing it. So that's a great step. The next study I want to discuss is a really very nice study. It's called the Alchemist, the aldosterone antagonist chronic hemodialysis interventional survival trial. And the reason this study resonates with me is because this was the only one which was using an old agent, spironolactone, and in a population where few trials are done, which is hemodialysis population. So, and this was not an industry-funded trial. It was, funded by the French authorities, and it took a long time to do this study. So, whenever you're doing these kinds of studies, they're really hard to do. So, really, congratulations to the investigator led by Patrick Rossignol, and he announced the results at ASN. So, there are a number of studies that suggest that spironolactone may be pretty effective in dialysis patients. But and there are some studies which show an astounding effect of this drug in dialysis patients. But to have an adequately powered, randomized, double-blind, multi-center trial takes a lot of effort. And this is what the Alchemist did. They randomized patients to spironolactone 25 milligrams every other day in an open label period during a 4-week run-in period. And if the patients had a serum potassium of 5.5 or more on 2 occasions during the run-in period or the day of randomization, then they were excluded. So they basically wanted to be sure that exposure to this degree of spironolactone doesn't cause hyperkalemia. Their primary outcome was time to first major adverse cardiovascular event, which was the expanded event, which included cardiovascular death, non-fatal MI, stroke, hospitalization for heart failure, or an acute coronary syndrome. The efficacy pretty much showed that the two drugs, placebo or spironolactone, were on top of each other. They had about 80 events in each of the two groups, about 700 patients or 650 patients randomized to the two groups. You have about 80 events per group. The hazard ratio is 0.98, and the 95% confidence interval is 0.73 to 1.36. So, you can see it's a fairly sizable trial, but the hazard ratio is squarely sitting at 1. They did have a slight improvement in cardiovascular death, but it was only numerical. P-value is 0.23. There, the hazard ratio was 1.26, favoring placebo. So spironolactone actually had a higher incidence of CV death, but not statistically significant. But if you look at the non-fatal cardiovascular events, they appear to be less in spironolactone. It's very hard to make sense out of these post hoc analyses because, the more and more you slice and dice the data, the more likely that you might have a false positive discovery. So the hyperkalemia events, about 12% in the spironolactone group, about 10% in placebo group. So substantial amount of hyperkalemia, 2% more though in the spironolactone group. Gynecomastia were about 15 patients versus 5. Arrhythmia by atrial fibrillation, more in placebo group. And SAEs were about equally common in the two groups. People who had hyperkalemia more than 6 were about equal in the two groups, 29.9% versus 27.3, maybe a handful more in the spironolactone group. Gynecomastia, certainly more events, and arrhythmia by atrial fibrillation, there were more in the placebo group. So what the investigators conclude is that in patients treated with chronic dialysis with at least one cardiovascular comorbidity, abnormality, or risk factor, treatment with spironolactone did not significantly reduce the incidence of primary composite outcome of non-fatal MI, coronary syndrome, hospitalization for heart failure, non-fatal stroke, or CV death. The treatment was well tolerated, and only hospitalization for heart failure had a significantly lower incidence in the spironolactone group. So that's basically the study. Meg, any comments on this?
Look, it was fascinating, and you're right, a huge achievement to get these big investigator-initiated studies completed. Look, it left me with more questions than answers, to be honest. The Achieve study is a similar study, a larger study, but again, testing spironolactone, and that's running in a number of countries worldwide. I've heard it's got about 2 years till it finishes, and for me now, I'm waiting for that. I don't know quite how to interpret this, and I'd love to see the Achieve study, and I think with the two of them together, we're probably more likely to get a good understanding of what the potential role might be.
Good points. So next, I'll talk about the impact of finerenone-induced albuminuria reduction on CKD outcomes in type 2 diabetes. It's a causal mediation analysis. And my apologies, I was the presenter on this, and I thought I'd talk about it because I didn't get to talk too much about it because it was a poster. So here's the background of it. We have a number of studies. There are actually 21 clinical trials that were meta-analyzed using a variety of agents. And, they use an endpoint of albuminuria. Median is 6 months. And when you look at the 30% reduction in UACR in those studies, it associates with about 24% reduction in the incidence of ESKD. So we have firmly established that, you have a reduction in albuminuria, you have a reduction in ESKD, but what we don't know is if you treat somebody and they have a reduction in albuminuria, how much of the treatment effect travels through albuminuria reduction and how much of it is independent of albuminuria reduction. And what I mean by treatment effect is the treatment effect on the kidney outcomes and cardiovascular outcomes. And we thought that in the 13,000 patients that we had studied with finerenone, we can quantify that because we had measured albuminuria at 4 months in every patient, and then we had quantified their outcomes long term. So this is what we are looking at. We are measuring the treatment, we are measuring a mediator at 4 months, and then we are measuring the outcomes. The effect that is mediated by reduction in log USCR is the dependent effect. So that is traveling through USCR. And the blue line shows you the effect that is independent of log USCR. What we find is that there's a marked difference in the mediation effect when we look at the kidney outcome, which is about 84% mediation. And when we look at the cardiovascular outcomes, it is about 37% mediation. So there's a big difference in the mediation that is happening with the two outcomes. And what we basically conclude is that USCR matters. Whether it is for screening or it is for post-treatment effect, it matters. And that's basically the sum and substance of it. Meg, any comments on this?
No, I really enjoyed reading your poster, Raj. I think it's these secondary mediation analyses are really important, not because they're the randomized analyses, but because they hint at mechanisms, they tell us which direction to push the research. So, really important, I think, that we do these studies and get the very most we can out of those large randomized studies. So well done, Raj.
Thank you, Meg. And over to you. What were your selections, Meg?
Raj, I found it was such a fantastic conference. There were so many things to look at, and it's really hard to pick out the highlights. But nonetheless, one study I wanted to pull out, and that was really because we've had so much done in the area of clinician support materials and using IT systems, using electronic medical record systems. A number of those studies have, they're all pushing what we can do and bringing research into clinical care, which I think is a fantastic thing to see. What I liked about this one, though, was it was properly powered. Some of these studies are small and you'd say exploratory. This one I liked because it was properly powered. And so I felt, they really put a lot of thought into the design of the study to make sure they were, answering a sensible question and pushing things forward. And what they were looking at was trying to improve the delivery of treatments in primary care. That was their overall objective. They looked at people with chronic kidney disease and high blood pressure, who, of course, are at high risk of progression. And we know from guidelines that good blood pressure control is one of the fundamental tenets of what care should be. They were also looking early in the piece when these patients are being cared for in primary care. Obviously, we want to prevent progression rather than picking them up when they turn up in yours and my clinics. So what they did was randomise the healthcare providers, primary healthcare providers, not nephrologists, in academic medical centres. And what the intervention was a clinician decision support in the clinic that prompted the use of blood pressure lowering recommended treatments, RAS blockade or hydrochlorothiazide. And what they did too was program it well. So they weren't just indiscriminately saying, don't forget CKD. They were picking out people. The algorithm was able to see whether they were already on maximum RAS or not, and if they were, progressed to the diuretic, and if they weren't, to prompt a decision. So I thought that was a good design too, in that it wasn't a blunt instrument. They were trying to nuance it. And their primary outcome was change in blood pressure, a good clinical outcome. So what they then found is that they were able to show a difference. That's the bottom line of this. And they did it with good power. They randomised 180 primary care physicians, and that meant there were 2,000 patients who were receiving the intervention or not. they look pretty typical of primary care patients, to be honest, certainly that we see in Australia. They were relatively older, 75 on average, 3/5 were female, most were white. And most of them were getting their blood pressure measurement at 180 days. So I think that's important to note. These are people who are returning, which is what you want in primary care and people with these comorbidities. And overall, they saw a reduction of nearly 3 millimeters of mercury in systolic blood pressure as a result of the prompt. Now, I thought that was a really powerful effect. This wasn't a direct randomization to a blood pressure tablet. This was a randomization to a prompt when everyone had access to the medications, and the medications are guideline indicated. So I thought that what's really important here is it's chiseling away at that gap between evidence and implementation. It's presumably a relatively cheap intervention once you've got everything done, coded up and designed. It's minimal impact on the care of the primary care provider's day, but clearly effective. So I thought that was exciting for clinical practice, but also exciting for this field of decision prompts and looking at how we can use technology to better deliver care. Certainly, as a clinician, I find a lot of the rollout of tech is more about getting rid of paper and moving on to a new system, and it's all about the process. But what I thought was really interesting here is it's not just about the process, it's about improving the care. So that's what I found a bit exciting about this one, and that's why I wanted to pull it out. It was a poster as well. It was a late breaker poster, and that poster session was such high quality. It was hard to move down that aisle. So I think that says how much interest there is in late breaking trials. So then the next, sorry, I should pause there, Raj. I don't know if you got a chance to have a look at that one or some of the other posters, but I'm interested in your thoughts.
Yes, I think it's a very exciting study, and some people might think, oh, 2.9 millimeters, that's not much, but at a population level, that's a pretty large effect that you're seeing. The p-value is pretty small. That means that it probably was consistent across the patients. And I think that the beauty of it is it almost costs nothing to give an intervention by just reminding the primary care physicians to escalate the drugs. And it happened. It happened only in 10% of the time in usual care and 24% of the time in intervention. So 2.4 times more common. So I think those are pretty strong numbers there with an intervention that almost costs nothing.
Well, that's a good point. That effect in blood pressure, that's comparable with the effect we see in the original trials that randomized people to placebo or a tablet. It's a very powerful effect. Yeah. So the next study I wanted to present was on one of the endothelin antagonists. Now, this is another class of agents that we have. We saw them presented a couple of years ago in the SONA study, where they did reduce nephropathy and prevent progression of kidney disease in diabetic kidney disease in a single study. These studies were in IgA nephropathy, and there was a companion study presented on FSGS. The PROTECT was a phase 3 study conducted in a number of countries and was double-blinded parallel study. It selected out people with IgA nephropathy who were at high risk of progressing, and all of whom were on maximum tolerated angiotensin blockade. What the study did was randomise 404 patients to sparsentan or irbesartan. So they were all assigned, had some renin-angiotensin blockade. And what the study presented was the results for eGFR slope. eGFR slope, of course, is going to become a really important endpoint for studies in rarer kidney disease, where we're not going to be able to randomise 11,000 patients like we were just talking about. So it's going to be a really important endpoint for the community to be aware of. Now endothelin angiotensin receptor antagonists are another agent. I think they've been overshadowed a little by the staggering results for SGLT2s and the MRA, the ASI class. but they are another agent with some very positive results there in the IgA nephropathy trial. Raj, what do you make of it all?
I think, Meg, we are moving into a very exciting times in nephrology, because not only are we looking at novel endpoints, but we also have novel agents. For example, atrasentan and sparsentan are completely different agents, because atrasentan only antagonized endothelin receptor 1, whereas the sparsentan is not just an antagonist of endothelin receptor, but also an antagonist of angiotensin 2 receptor. And that's why it's called a dual endothelin receptor antagonist. And that's why you will see that in patients who are on sparsentan, they are matched to irbesartan, because you're basically trying to tease out the effect of only endothelin receptor antagonism and not the angiotensin 2 receptor antagonism. So that's why you're matching it not against a placebo, but irbesartan. To me, the IgA nephropathy study is really an important one, because, as you know, the drug has been approved in the United States for treatment of IgA nephropathy, but it was contingent upon a longer-term study to show that if the slopes have changed. And when we look at the p-value of the slopes, the p-value is 0.058. The nominal value is just missed, and I don't know what will happen as far as the regulators are concerned with this. The drug is available under a REMS program, which is a restricted practice, and they're basically concerned about hepatotoxicity, and a lot of monitoring is needed. So on the other hand, when we look at the FSGS program, it's using a much higher dose, 400 titrated up to 800, which is twice the dose of what they are using in IgA nephropathy. And clearly, FSGS is reducing proteinuria, but they're not changing the slopes. So it's a little bit of a disappointment there. I think that we still will learn a lot once we analyze these data and look at what is the real relationship between the reduction in albuminuria and the long-term outcomes, much like what we have done with the causal mediation analysis in the Fidelity trials. Is there a relationship, or is there not a relationship, a causal mediation analysis? So I think we can learn a lot from these data, and time will tell how the camel will sit.
Indeed. Do you think it's play of chance, the size of the studies, or do you think FSGS might truly be behaving in a different way?
There's a lot of heterogeneity here. There's different degrees of proteinuria, different degrees of GFR. And, these are really looking to answer the question, is the long-term slopes different? And, you're reducing one, not the other. Is it a dose, where you're using 400 and 800, whereas the IgA nephropathy was much lower dose? What is the adherence to these therapies? What are the hemodynamic and non-hemodynamic effects? There's so much that can go on, so it's very hard to pinpoint why didn't it work. But I think we can learn a lot from these data that people have collected.
Yeah, I totally agree with all of that. I do wonder too about the possible heterogeneity within an FSGS population. I think there's a lot we're still yet to learn about what we label as a single condition, perhaps, but we know that it's more complex than that, don't we?
Yeah.
Well, that's probably all we have time for. Another packed ASN. So it's really becoming a fascinating must-do event of the year, isn't it?
Absolutely. And of course, for the slide summaries, I have to thank the ASN to field this, and head over to the CMF at Cardiometabolic Forum if you want to look at these slides. Join our mailing list and follow us on social media, so that we can stay in touch with you and let you know the moment an update goes live. All that remains for me to say is thank you, Meg, for a great discussion today, and thank you to all for joining us. Bye.
Thanks. Bye, everyone.